Hi all of you, welcome back. So we were discussing about the disorders of enamel. Now we will discuss about disorders of dentine. We have got some hereditary disorders, which is the dentinogenesis imperfecta and dentine dysplasia, which is most important one, and one which is non-hereditary, which we are going to discuss, which is regional odontoclasia or ghost teeth. Okay, so we'll start with the first one. Before that, I want to give you some basic understanding. So as we told in the previous lecture about amelogenesis imperfecta, it should be like a defect in enamel where there is no systemic disorder. Similarly, here also this condition applies. It's a defect in dentine without any systemic disorder. So there should not be no systemic, should be there. Okay, it's a defect in dentine without any systemic disorders or syndromes. But now, there are some syndromes associated with this, with dentine disorder. Just I'll discuss that. Okay, so which will not come under the definition of the dentine developmental or hereditary disorders of dentine. And what are the syndromes associated? One thing we all know, it's osteogenesis imperfecta. Then just two more. There are much more, but just two more to remember. One is Ehlers-Danlos syndrome. Okay, Ehlers-Danlos syndrome. And finally, we have the rickets. Okay, rickets 2, that is vitamin D dependent and vitamin D independent. Okay, independent rickets, vitamin D dependent rickets and vitamin D independent or vitamin D resistant rickets. Okay, so these are the three syndromes at least you have to know. Now I'll just come on to the basics on how what is the problem actually occurring in case of the disorders of dentine. Okay, the basics I would say. Okay, the basics behind, and the basics is it's the problem with matrix. Okay, it's the problem with matrix formation. It's not the formation of the mineralization or like that, as we saw in enamel hypoplasia or enamel amelogenesis imperfecta, where even the maturation and the calcification was affected. Here the matrix formation is being affected. Okay, and when we consider the matrix in dentine, we can divide them into two parts. Okay, one is collagenous matrix, and the second one is non-collagenous matrix, isn't it? So what is collagenous matrix and what is non-collagenous? If I say what is collagen, it's collagenous. What is collagenous? Means collagen. It's 85 to 90% of dentine is basically what, or the 85 to 90% of the matrix of the dentine is collagen. Okay, so the gene which codes and which is what, type 1 collagen, you know that, type 1 collagen. Okay, and the gene which encodes for that is col1A1 and col1A2. Okay, col1A1 and col1A2. Okay, then there is non-collagenous proteins, which is that DSPP, dentine sialophosphoprotein. Okay, dentine sialophosphoprotein. So if we split this, okay, there are three components for this, and the gene name of the gene is like this. This is col1A1 and col1A2. The gene is very easy, DSPP gene. So the gene is all the same. So this DSPP is basically a non-collagenous protein, and the gene is DSPP gene, dentine sialophosphoprotein gene. Okay, now, so if we split this, okay, if we split this, we will see that this can be cleaved or broken down into three components. One is dentine sialoprotein, okay, dentine phosphoprotein, or that is dentine sialophosphoprotein, dentine sialoprotein, and finally it's dentine glycoprotein, DGP. Okay, so it's three components. So just know the basics. Okay, so the gene is this DSPP gene. Now we will come on to the real facts. If there is a problem with this gene, what is the disease? The collagenous gene, the collagen formation gene. What's the name of the disease? It's osteogenesis imperfecta. Okay, which we have already seen. It's related to, because even the bone will be affected, because bone is also collagen. Bone also contains collagen. So the disease is osteogenesis imperfecta. Here it is different. It's only dentine being affected. Okay, here only dentine is being affected, and which all diseases are included in this? One, you know, it's dentinogenesis imperfecta. Okay, and the second is dentine dysplasia type 2. So it's dentinogenesis imperfecta and dentine dysplasia type 2. The genetic disorder behind dentine dysplasia type 1, textbooks are saying that the genetic defect like in relation to the type 1 is not much recognized. Okay, so the problem with DSPP gene, if there is a problem with DSPP gene, then the disorder will be dentinogenesis imperfecta or dentine dysplasia type 2. Okay, if the problem is with the COL1A1 or COL1A2 gene, it's the disorder is osteogenesis imperfecta. Okay, because collagen is also a part of bone. So this is some understanding you have to know with regard to some basics on dentinogenesis imperfecta. Now, similar to what we have drawn with the amelogenesis imperfecta, here also we have to draw some charts, but more importantly, it's not the genetic defect. Okay, genetic defect we have already discussed, but more importantly is the classification. So what comes under each? So different types of classification has been discussed. One is Shields classification of dentine disorders, then revised classification of Whitcop. Okay, Whitcop. Then we have Mendelian inheritance of man database. Okay, Mendelian inheritance of man, MIM database. This is accepted short form. Okay, Mendelian inheritance of man database. Okay, which is the latest classification, and some features. Okay, which are related. Shields classification is the oldest one, and I'll write DGI, means dentinogenesis imperfecta for each. So DGI, the oldest classification is Shields, DGI 1, DGI 2, DGI 2, and DGI 3. Okay, again vertical learning. Okay, Whitcop's classification as well as the Mendelian inheritance of man classification, they removed this. Okay, they have removed the type 1 from both. Okay, they don't consider, because DGI 1 is basically what? Osteogenesis imperfecta. Okay, DGI 1 is nothing but it's osteogenesis imperfecta. So they say that it's no more included under dentinogenesis imperfecta, so they have removed that. Only Shields in its initial classification have described it. Okay, now how to remember the next two? So about revised Whitcop, it is DGI 1. So because the 1 is already being removed, he named this as 1 and this as 2. And here it is 1 and 3. Okay, he said this is features, I'll tell you, but it's like this. So how you can remember? This is the third one. Okay, MIM is the third one, so it's 1 and 3. This is the second one. The Whitcop is second one. It is 1, 2. Okay, so 1, 2 is second one. 1, 3 is the third one. Okay, 3. Okay, so this is how you have to remember it. Okay, now I will tell you features of each. So this is basically the DGI 1, as I told you, it's osteogenesis imperfecta. Okay, now what is the DGI 2 and DGI 3? So the DGI 2 is like I'll discuss based on Shields. Okay, the other two you just have to know. Okay, I'll discuss based on Shields. Okay, DGI 2 according to Shields is both of this are basically what? Both of this is known as isolated opalescent teeth. Okay, this is first thing you have to know. Both are called the isolated. Both of these are called isolated opalescent teeth. Okay, both isolated because there is no osteogenesis imperfecta. It's isolated opalescent teeth or opalescent teeth. Okay, now when it comes to the type 2, DGI type 2, which is also known as hereditary isolate. Okay, the other name is hereditary isolate. Okay, it's not isolated opalescent teeth. Isolated opalescent teeth means it's a common name for 2 and 3. Okay, but the 2 is specifically known as hereditary isolate, and this is known as Brandywine isolate. Okay, Brandywine isolate. Brandywine isolate. Okay, so this is the other names for each. Okay, and you have to know this classification. They'll ask you, according to revised Whitcomb, Brandywine isolate is what? 2. According to the MIM classification, Brandywine isolate is the DGI type 3. Okay, then the one more thing you have to know here is the MIM classification. They also included dentine dysplasia 1 and dentine dysplasia 2 in their classification of the their classification. Okay, just nothing but much bigger, like just to know. Okay, which classification included dentine dysplasia. It's under disorders of dentin. It is MIM. Okay, in others they considered it as a separate disorder. Okay, so that's all. So what is the genetic defect in these? All these? What is the genetic defect? It's common except in type 1, which they actually didn't know. Okay, and even some are saying that it is same. Okay, so what is the genetic defect in all these? It's DSPP gene. Okay, dentine silophosphoprotein gene is being affected, so they should have a common origin. So this is not very difficult, only the names are to be known: osteogenesis imperfecta, hereditary isolate, Brandywine isolate. Okay, so now we will come on to each separately. Again, you should draw charts. In this case, we have only 2 charts, 2 columns. Okay, we'll be drawing 2 columns. In the first column, we'll divide again this columns into 2 equal halves. Okay, and then we will start. Okay, so in this column, we are going to discuss dentinogenesis imperfecta, and in this column, we are going to discuss dentine dysplasia type 2, only type 2. Type 1 we will discuss separately. Okay, discuss separately. So this is dentinogenesis imperfecta and dentine dysplasia. Now we have to further divide dentinogenesis imperfecta. What is the other name for dentinogenesis imperfecta type 2 and type 3? It's hereditary opalescent dentine. Okay, we have already discussed here. Okay, in the previous, hereditary opalescent dentine, which is common or isolated opalescent teeth. Okay, or hereditary opalescent teeth or dentine. Okay, and they have given also another name, which is cap de Pons teeth. Okay, cap de Pons. So these are the other names for dentinogenesis imperfecta in general. Okay, features we will discuss. So this will include features. The second column will be for features. Now, what is the mode of inheritance? In both in dentinogenesis imperfecta as well as dentine dysplasia, the mode of inheritance is autosomal dominant. Autosomal dominant. Whereas in amelogenesis we saw both X-linked, autosomal dominant and autosomal recessive. Here it is the autosomal dominant. And here both primary and permanent teeth are affected. Okay, both primary and permanent dentition are affected, but primary dentition is affected more than permanent dentition. Okay, primary dentition is affected more than permanent dentition. Then very thin dentine is the typical, naturally very thin dentine with blue to brown discoloration. Okay, blue to brown discoloration. So blue to brown discoloration. So this is the color. The amelogenesis imperfecta we saw it was yellow discoloration. Here it is blue to brown discoloration. Okay. Now we are going to discuss, much more important, is radiographic features. This is really important. Okay, radiographic features. In radiographic features, we have to discuss this under 3 headings. Okay, radiographic features will be discussed under 3 headings. One is general radiographic features. Okay, general radiographic features, and then will be the one which is there in type 2 as well as in type 1. Type 1 is osteogenesis imperfecta. Okay, type 1 and type 2, and other will be for type 3 alone. Okay, so we will discuss under 3 headings: general, type 2 and type 3. Okay, the general radiographic features for all kinds of dentinogenesis imperfecta, it is bulbous crown, cervical constriction, okay, the tooth will be constricted, okay, it will be like this, just an exaggeration, cervical constriction and thin roots, okay, the roots will be thin, okay, just an exaggeration for you to remember things, okay, so it's like this, okay, cervical constriction and thin roots. So this is seen in all the type 1, type 2 and type 3, whereas in type 1 and 2, okay, 1 is osteogenesis imperfecta, so 1 and 2 or 2, its features is early obliteration of root canals and pulp chambers, okay, there is obliteration of, so this is one question they ask you, obliteration of pulp chambers and root canals, okay, root canals. This is the radiographic features specifically for type 2, okay, whereas in type 3, so one more thing, obliteration of pulp chambers, even they have asked, like they have considered as a feature which is characteristic of dentinogenesis imperfecta. So they have not differentiated between the type 2, type 3. So even like that also you consider. But when they specify, type 2 is the one which have got this obliteration of pulp chambers, and type 3 has got expanded pulp, exact opposite. Okay, expanded pulp. Okay, expanded pulp chambers instead of being obliterated. Okay, and thus it's called the shell teeth. Okay, shell teeth, and there is, due to this reason, there will be pulp exposure because the pulp is very expanded. Okay, this is, if this is the tooth and if this is expanded pulp chambers, so exposure is very easy. So there will be multiple pulp exposures, and due to this there will be periapical radiolucency. Okay, periapical radiolucency. So this is the features. Okay, so that's the difference which you have to differentiate. Here it is shell teeth, whereas the type 2 is obliteration. Okay, general features are very common for both. Okay, then one more thing here, just forget to tell you that this gives, this bulbous crown, cervical constriction, thin roots, gives the tooth a specific shape. This is called tulip shape. So this has been asked. Okay, tulip shape. Okay, and another thing, what is the reason for this obliteration of root canals? It's the extensive deposition of secondary dentine. Okay, extensive deposition of secondary dentine has caused this obliteration of pulp chambers. Okay, so hope you remember this chart. Okay, one thing is the basic features, autosomal dominant. Okay, autosomal dominant, it's both in primary and permanent, but more common in primary. Very thin dentine, blue to brown discoloration. Radiographic, general features type 2 and type 3 separately. Okay, now, so that was about dentinogenesis imperfecta. In dentine dysplasia type 2, the other name you should know for this is coronal dentine dysplasia. So type 2 is the one which is coronal. Okay, type 2 is coronal dentine dysplasia. So every features will be related to the external exposed part, that is crown. Okay, the coronal dentine dysplasia. So that's the reason why they have included with dentinogenesis imperfecta, because that exposed crown is being affected. Okay, and also the genetic defect is same, isn't it? Now, similarly, like we did the classification of the type, the dentinogenesis imperfecta type 2 and type 3 separately, here we will discuss primary and permanent separately. Okay, primary tooth and permanent tooth will be discussed separately. Why? I'll tell you just now. Because this has got similarity with this, this has got similarity with this. Okay, that's the reason. So here it is type 2, type 3 being discussed separately, here is primary, permanent discussed separately. Okay, so what are the features? One is the color, that is blue to amber color. Okay, blue to amber color, which is actually a general feature. Okay, it was not blue to brown or blue to okay, write it like blue to brown, don't confuse. Blue to brown or blue to amber brown. Okay, blue to amber to brown, whatever. So it's blue to brown, which is actually a general feature, but consider here. Okay, and similarly there is bulbous crown, cervical constriction, thin roots, which is also a general feature. Okay, that is bulbous crown. Everything was a general feature of the dentinogenesis imperfecta. So it's bulbous crown, the tulip shape. Okay, bulbous crown, cervical constriction, all this. Okay, which is actually a general feature. Thin roots, all same. Okay, but more importantly here, what is really important is there is obliteration of pulp chambers. Okay, obliteration of pulp chambers. Okay, this is what is really important, which is having the similarity, as I told you, with the type 2. Okay, the type 2, obliteration of pulp chambers. Okay, then when we come on to permanent teeth, it's the color is normal. Okay, where we saw it's a blue color here, it's normal color. Okay, it's normal color. Okay, beside features, everything they have not specified, so maybe it's the same like bulbous and everything, but the color is normal. Here, much more important is the feature which is similar to type 3, which is enlarged pulp chamber. Okay, expanded or enlarged pulp chamber. But here, the difference is they are not telling that it's a shell teeth. Instead, they're saying that it's a thistle tube shape or flame shape. Okay, it's a thistle tube or flame shape. Okay, flame shape. Why? If I take an anterior teeth like this, okay, usually you know what is a flame shape. It's thistle tube. You know what is thistle tube? Like, I don't know how I'll draw this. Yeah, it's like this. Okay, it's a thistle tube. You can just get a picture when you search internet. Okay, so this is what happens. It's expanded pulp chamber here, and when it comes down, it's constriction kind of thing. So it's a thistle tube expanded. It's almost like normal, but actually it is a bit expanded. Okay, it's expanded. So it will give you that thistle tube appearance. It's in here it is constricted and there it is expanded. So this will give you a thistle tube or flame shape appearance. Okay, thistle tube or flame shaped appearance. So that's the slight difference. So type 2, 3 and primary permanent, the radiographic features are almost similar. Okay, almost similar. The difference is type 3 is basically shell teeth and the permanent is thistle tube or flame shaped. Okay, so this is the classification or the description of dentinogenesis imperfecta and the dentine dysplasia. You have to just learn it once again. Everything in what I've explained can come as a question, so you have to just remember this chart, revise 3-4 times, it will be there. Okay, this chart will go into your mind as a photographic memory. Now, one more thing I just want you to remember with regard to the dentinogenesis imperfecta is there is undefined, is a point I want you to write, undefined DEJ. The dentino-enamel junction, the junction between dentine and enamel is undefined. Okay, so that is there is no scalloping. Okay, if you have studied your the dental histology, you will see that there is a scalloping between enamel and dentine. This scalloping is not there, so the junction is actually a flat kind of thing. So there is no interlocking between enamel and dentine. So as a result, enamel is lost. That's the funniest part. Okay, enamel is not lost due to any defect. There is a normal enamel, but enamel is lost because there is no scalloping, and this enamel is lost. And dentine below this is already being affected. So this really causes pulp exposures and all those things. Okay, so this is something we have to know. Now we have discussed dentinogenesis imperfecta and dentine dysplasia type 2. Now we are going to discuss dentine dysplasia type 1. So dentine dysplasia type 1, the other name is radicular dentine dysplasia. So that you can, like they can ask you, okay, the radicular dentine dysplasia. So type 1 is radicular and type 2 is coronal. Actually, what we really feel is crown is up and root is down, so it should be opposite, but actually it's not. Type 2 is the coronal and type 1 is the radicular. Okay. So the definitions are all similar. It's a disorder of dentine where there is no systemic. Okay, there is no systemic, almost same for all. Okay, there is no systemic correlated disorders. Okay, but now the clinical features are completely different because it is radicular. Okay, so it will be associated with the root. The crown will be normal. Okay, and this has been also called another name, that is rootless teeth, due to the same reason, rootless teeth. Most of the time the roots are absent. Okay, and due to that same reason there will be extreme mobility. So this is one feature which you have to know, it's extreme mobility of the teeth. Okay, extreme mobility of the teeth. The coronal dentine is normal. Okay, the coronal dentine is normal, only the radicular dentine is being affected, and there is most of the time no root and there is extreme mobility. And if the tooth like erupts, okay, usually may not erupt, but if at all it erupts, it can cause premature exfoliation. Premature exfoliation. Okay, premature exfoliation because of this extreme mobility. Now, they have been classified into 4 different classes: 1A, 1B, 1C, and 1D. If you have studied this for your short answers, you would have already learned this. I'll just show you an image. So, yeah, 2 images came. It's fine, let it be there. Okay, so as I told you, there are 4 different types: 1A, 1B, 1C, and 1D. Okay, so this is 1A, it's 1B, it's not, I don't know if it's very clear, 1C and 1D. So see this. Okay, it's the pictures are self-explanatory. So the few things which you have to know is, one is, this is usually seen in deciduous, this is usually seen in deciduous. Okay, I'll explain it here. This is seen in, okay, whereas this is seen in, the rest of it mostly is seen in permanent. So one is usually seen in deciduous and other are more in permanent. Okay, to be very specific, 1B is more common in permanent. Okay, 1B is more common in permanent, 1A is more common in primary. Okay, now let us see what happens. Here it is, there is no detectable root at all. In 1B there is no root at all. See this, there is only no root, no pulp. Okay, there is no root, no pulp, and there is frequent periapical radiolucency. Most of the time there is periapical radiolucency. Whereas when you come on to 1B, there is a crescent shaped, there is some attempt for formation of the root, and there is a crescent shaped pulp chamber. Okay, there is a crescent shaped pulp chamber. Okay, then when it comes to 1C, it is 2 crescent shaped pulp chambers. 2 crescent shaped pulp chambers, and the root formation is slightly more. Okay, then finally coming on to 1D, if it's whether anterior or posterior, we will see much more. Okay, formation of the root and the pulp is much better. Okay, it's almost, the root is like, the pulp chambers are visible, there is near normal root length, but the problem is there will be enlarged pulp stones. Okay, so pulp stones specifically is a feature of 1D. Okay, there is enlarged pulp stones. See here, it's enlarged pulp stones. So this is what you have to know. There is no root at all. Then there is a crescent, single crescent, double crescent pulp stones. Okay, so this is something which you have to know. Okay, so the radiographic feature, now just to differentiate the radiographic feature, okay, a page completely left, no problem. Now a radiographic feature of dentine dysplasia, okay, type 2, you can see in primary it is obliteration of pulp chambers. Okay, and in permanent it is tissue tube or flame shaped. Whereas in dentine dysplasia type 1, if you come, you can see what's the most important feature is this pulp stones. Okay, so pulp stone is the most important feature. Okay, radiographically. Now, more importantly, I'll just discuss histopathology here. Dentine dysplasia type 1 has got a very important histopathological feature. Now, one more thing I just want to add is the periapical radiolucency seen, which is also a radiographic feature. So, radiographic feature can be one, pulp stones can be seen, but not very like, yeah, just to add, this pulp stones in radiograph will not be very much prominent. More important is the periapical radiolucency. So coming on to the histopathologic features. So far we have discussed only the radiographic feature, isn't it? Radiographic features. Okay, radiographic features. Don't confuse. Now we are going to discuss histopathology. So far we have not discussed anything about histopathology. Okay, so remember that. That's what I was asking, like saying you, that they will ask you, they'll confuse you. So histopathology of dentine dysplasia type 2 is important. Okay, type 2 is important. As I told you, what is happening here? What is normal? The coronal dentine is normal. Okay, so the coronal dentine, while the formation, when we see, the coronal dentine will be normal. Okay, whereas there will be disorganized whorls of the radicular dentine. Okay, there will be disorganized whorls, whereas the coronal dentine will be normal. Okay, this again not very perfect, but still this is like coronal dentine, and the whorls of radicular dentine which is actually abnormal. Okay, now this will give you a feeling, like a look in histopathology, that lava is flowing. Okay, there is stream of flowing of lava around the boulders. Okay, just remember like that. Okay, stream. Okay, stream flowing. Okay, stream flowing around boulders. Okay, this is the term which is given in the textbook. It's like this. Okay, this is the stream outside normal dentine, and the boulders, what they see is this. Okay, disorganized internal dentine, whorls of disorganized dentine. Okay, so this they have asked in different ways. One is, what's a histopathology? It's a stream of stream flowing around boulders or cascades of dentine, and then another name is cascades of dentine. Another thing they could possibly ask you is, what is this actually? Okay, what is the reason for this? Okay, one reason is, the typical reason is this particular disorganized dentine over normal dentine. And why is this being formed? It's just attempt to form a root structure. Okay, so it's what? It's nothing but it's an attempt to form the normal root structure, but it is not happening. Attempt to form root structure. Okay, as an attempt to form the root structure, the coronal will become normal, but the radicular will be disorganized. So this is histopathology of dentine dysplasia type 1. Okay, dentine dysplasia type 2, the histopathology is not very significant. More important is radiographic. Okay, so radiographic for type 1 is the more importantly, it is a periapical radiolucency and also the pulp stones. Okay, so that is about dentine dysplasia. So you have to revise it today itself, otherwise you'll forget things off. Okay, then coming on to another very important topic and the final topic for today, which is regional odontodysplasia. Okay, regional odontodysplasia. Okay, odontodysplasia. The other name is, you have got different names, ghost teeth. Okay, they have got different names. Regional odontodysplasia, ghost teeth. Other names are odontogenesis imperfecta, not dentinogenesis. It's odontogenesis. All teeth formation is being affected, so it's odontogenesis imperfecta. It's enamel, dentine, and pulp. All the three are affected, so it's odontogenesis imperfecta or odontogenic dysplasia. Okay, not dentine dysplasia. It's odontogenic dysplasia. Okay, then we have the other, like which I've already told, the ghost teeth. Okay, so these are the three names: odontogenesis imperfecta, odontogenic dysplasia. So like dentinogenesis imperfecta, instead of that odontogenesis imperfecta. Instead of dentine dysplasia, we have odontogenic dysplasia. So these three names are very important. They can ask you. Okay, so this is basically the other names. Okay, and very important thing, you have to know that this is non-hereditary. So if they ask you there is a non-hereditary disorder of dentine, it is this regional odontodysplasia. Though all the structures are being affected, it is the dentine is most commonly much more affected. Or they can ask you which of the following is not hereditary. So then they'll give you dentine dysplasia, dentinogenesis imperfecta, amylogenesis imperfecta, everything. So remember, this is non-hereditary. This is very, very important point. And it affects the structures, enamel, it affects dentine, it affects pulp. So there's another very important difference. Okay. And the cause, as I told you, it's non-hereditary. So what could be the cause? There are different causes being attributed, but the most common theory is alteration in vascular supply. Okay, alteration in vascular supply is being affected. Okay, vascular supply. So this, due to this alteration in vascular supply, which is causing this, it's seen that it's associated with some vascular nevi. Okay, that's the reason they say that it could be a possibility that is alteration in vascular supply is causing this, because it is being associated with various vascular nevus. Okay, now clinical features. Clinical features, when it comes to clinical features, one is delayed or failure eruption, because every structure is being affected, so there will be delayed or failure of eruption. Okay, failure of eruption. Okay, then if at all it erupts, it goes for early exfoliation. Okay, early exfoliation. Okay, another thing. And the problem, as I told you, pulp is affected, dentine is affected, so pulpal involvement will be very quick. Okay, so one more thing, it's most common, the most common site is being asked. Okay, it's maxillary anteriors. They can ask you this. Maxillary anterior is the most common site being affected. Okay, so which can lead to delayed or failure of eruption, if at all erupted, early exfoliation. And as pulpal involvement is very fast, they can lead to abscess formation. Okay, also structural involvement will be there, because enamel, dentine, everything is affected, so there will be small crowns, small irregular crowns structure. Okay, then there will be discoloration, yellow or brown, depending upon enamel or dentine. Okay, so yellow or brown discolorations, everything is there. One more thing they've added is non-inflammatory gingival enlargement. I don't know what's the reason behind that, but there is non-inflammatory gingival enlargement. Okay, so most importantly, just know some features, which is whatever you can remember. I don't know, they will ask you the features associated, but whatever they ask you as a question, as a detailed, they will ask you something. They will include definitely these 3 points: enamel, dentine, pulp affected and non-hereditary. So that are the key points. Whatever else they ask, the key points is these 2. Okay, now the radiographic features. So radiographic features, typically thin enamel, thin dentine, expanded pulp. Okay, which will give a ghost tooth appearance. Okay, like there is nothing, there is no enamel, no dentine, like it's completely like a ghosty appearance. Okay, so, and there is a lack of contrast between enamel and dentine, lack of contrast between enamel and dentine. Okay, between enamel and dentine. And there will be definitely in the pulp, as the pulp is that there is a trying of formation of the calcification within the pulp, trying to form the dentine, and also there will be pulp stones. Okay, there will be pulp stones. Okay, now with regard to this, the histopathology part. Okay, there is a sentence given in Schaeffer's and in Ames 2012. Not that I want you to read Schaeffer's completely, but there was a funny thing happened. They gave exact line which is there in the Schaeffer's. Okay, a line exactly in the Schaeffer's they asked as a question. Just write it down. It's marked reduction in amount of dentine. Marked reduction. So histopathologically, marked reduction in amount of dentine with widening of predentine layer along with large areas of interglobular dentine and irregular pattern of dentine. Large areas of interglobular dentine. We'll study this in dental histology. What is interglobular dentine? Interglobular dentine with irregular patterning. Okay, irregular patterning of dentine. Okay, so this is one sentence. Is seen in. That was the question. So this exact sentence in Schaeffer's. So there is marked reduction in the amount of dentine with widening of the predentine and areas of interglobular dentine with an irregular pattern. Just learn the sentence as such if they repeat it again. Okay, and they can ask this time, maybe they'll ask you simply one part, that is widening of predentine with large areas of interglobular dentine is seen in. Like that also they can ask you. Okay, so this is something which you should know. Okay, so that is about the developmental disturbances in relation to structure of teeth. We have discussed the enamel related the previous class. In this class we started with dentine. I'll just go through it quickly. Okay, it's non-systemic syndromes associated. Okay, then we said it's a matrix formation problem. So it's COL1A1 and COL1A2, it's osteogenesis imperfecta. If it is DSPP gene, it's dentinogenesis imperfecta and dentine dysplasia type 2. Okay, then coming on to the classification, it is 3 types. It's Shields, Whitcop and MIM. Okay, it's 1, 2, 3, 1, 2 and 1, 3. Okay, this first one is osteogenesis imperfecta. This has removed the second and third has removed them. Then another thing is osteogenesis imperfecta. Then we have hereditary isolate and Brandywine isolate. Okay, then coming just the features of dentinogenesis imperfecta and dentine dysplasia, basic features. Okay, which is the tulip appearance. Okay, then we have the type 1 having the obliteration and type 2 having the shell teeth, whereas in dentine dysplasia type 2, it's primary and permanent with features of obliteration here and enlarged pulp chamber with thistle tube appearance there. Okay, then there is undefined DEJ without scalloping. That's another feature you have to know. Then type 1, which is radicular. Okay, type 2 was coronal, and the feature you have to know is stream flowing around boulders and cascades of dentine. Okay, which is just an attempt to form the root structure. And finally the types 1A, 1B, 1C, 1D, it's absence of root, 1 crescent, 2 crescent, full with pulp stones. Okay, then we have regional odontodysplasia, ghost teeth, odontogenesis imperfecta, odontogenic dysplasia. Okay, it's non-hereditary with affecting all the 3 structures. Okay, clinical features, typical features, radiographic, ghost teeth and lack of contrast with pulp stones. Histopathology, yes, there is reduction in amount of dentine, widening of predentine, interglobular dentine. Okay, so that's all for this session. By this we will complete with the dentine, like the disorders of the teeth. In the next session we will start with some of the syndromes associated with developmental disorders. You know that we have already discussed the developmental cyst already, the nisopalatine duct cyst and all those in the cyst part. So that is not being discussed in this. We'll discuss next. We'll start with the syndromes associated with maxillofacial skeleton, developmental syndromes and disorders associated with maxillofacial skeleton, where we will discuss the cleidocranial dysplasia, all those. Okay, Apert syndrome, Krausen syndrome, everything will be discussed in the next session. So see you in the next session. Goodbye. Take care.